fun shady space. I don't have control of it turning it on and off. Right? You just press this button here when it's red. Yeah. Just turn it off whenever you're pretty simple for all. And theirs can be turned off too. And so if they don't turn it on, I'll yell out, turn your mic on. It's like I have control of all the mics, and you have individual control of them. Simi. Yes. I don't have the mind, so I think we're doing 10 and 5. 10 for the rotation and 5 for discussion. There's been some that have been less. I don't know if you have those ready. Do you have another sheet? So there's another sheet up there. So 1 to 3. It says 8 long, 10 minutes, 5 and 6 short. So we'll do 8 10-minute ones, and then 6, and then we'll do 3. Okay.
Session. Before you dismiss everybody, let me come up here and put it out. You're remembering, it's not really super important.
Good morning, everybody, or good afternoon, everybody. We're going to go ahead and get the third session started. I'm Dr. Baker from the University of Utah. This is Dr. Morgan from NYU. Hard to get used to that. And the session this afternoon is on complex surgical techniques. And I think maybe Chris and Nick can tell me. We've got 8 papers that are 10 minutes and then 5 for discussion and a few shorts at the end of this, right? Okay. Best judgment. Okay. All right. So the first paper is entitled Transcriptome-Derived Ampullary Adenocarcinoma Classifier, Prognostication and Chemotherapeutic Response by Dr. Lin and colleagues from Nanjing Medical University in China.
I appreciate for the introduction. Good morning, good afternoon. I'm Dr. Zheng Lin from the Pancreas Center of the First Affiliated Hospital of Nanjing Medical University. So it's a great pleasure to participate in this meeting. Last year in Cincinnati, left me with wonderful memory where I presented preliminary data on the transcriptome subtyping in ampullary cancer. So today I will share our latest advancements in molecular subtyping concerning prognosis and chemotherapy responses and therapeutic translation. So no complete disclosure. Ampullary adenocarcinoma, though rare, carries a 5-year survival rate nearly 50%. The current widely used histological subtyping, including intestinal and pancreatic subtypes, have 2 critical limitations. One is diagnostic overlap. Even immunohistochemistry markers often show ambiguous staining patterns. Another is limited clinical utility. Existing subtypes fail to reliably predict chemotherapy response or survival outcomes. So the NCCN guideline recommended subtyping based on three subtypes, including intestinal, pancreobiliary, or sometimes mixture subtypes. However, this subtyping is unreliable. And in addition, the value of subtyping for predicting benefits of adjuvant chemotherapy outcomes are conflicting. So can we develop a classification to guide clinical decision for patients with these rare tumors? My answer is through the multiple omics. Recent study make effort to link multiple omics with clinical outcomes in ampullary carcinoma. Multiple center from US built a genomic classifier which defined distinct clinical cohort with marked difference in expected survival. Another multiple center study created a multiple signature-based classification, which highlighted the promising efficacy of targeting Wnt pathways. Genomic analysis published in this year revealed three distinct clusters, among which the most aggressive with poorest prognosis show a feature of focal adhesion. However, no transcription-based classification has been proposed. So in this study, we aim to build molecular subtypes based on gene expression profiling. And here's our data. First, based on single-cell transcriptomic, we identified 9 major cell types in ampullary cancer according to their exemplary gene expression. Then we assemble a retrospective cohort including 113 patients with this cancer. In our center, the histological pancreobiliary subtypes exhibited a significant shorter survival than intestinal or mixture subtypes. And we're also using bulk RNA sequencing to analyze the gene profiling of these patients, highlighting the ampullary carcinoma overexpressed pathways in Wnt, interleukin signals, or cell cycle ECM receptor interaction. So we utilize unsupervised NM to establish the NM's molecular subtypes comprising 2 major subtypes. 30% of patients fell into the subtypes with poor prognosis, named C1 cluster, while the remaining severe 70% patients exhibited better outcomes, demonstrating a 5-year survival rate approaching 75%. Pathological subtype analysis revealed that a higher proportion of PB subtype tumors in C1 cluster, where the C2 class is predominantly consistent of intestinal subtypes. Here is the compare of the gene expression of molecular signature between 2 subtypes. So C1 is dominated by epithelial mesenchymal transition as an EMT signature and myogenesis, while C2 is characteristic by preserved epithelial features. Notably, the intestinal subtypes have higher proportion of C2 features. The association of AMS with previously established classifier show that C1 tumors linked with mesenchymal or basal-like malignancy. So histopathological observation confirm that C1 tumors display more abundant stroma and fibrosis. Through deconvolution, we quantified the abundance of different cell types for each tumor, and the C1 tumors show increased fibroblasts. Moreover, C1 tumors highly express EMT-associated transcription factors, such as SOX4 or CADA4, while C2 predominantly express intestinal epithelial transcription factors like CDX2 and KF2. Notably, in a subgroup analysis of patients who completed post-operative adjuvant chemotherapy, we found the time to tumor recurrence strongly correlated with tumor EMT levels. Patients who remained recurrence-free for over 5 years after surgery exhibited the lowest EMT level. These results suggest that the C1 subtypes of ampullary cancer characterized by basal-like features, stromal enrichment, and elevated EMT may correlated with poor prognosis and diminished chemotherapy efficacy. So to validate the relationship between the relationship between MS molecular subtype and the chemotherapy sensitivity in ampullary cancer, we established tumor organoid from 11 patients with these rare tumors, and it demonstrated that C1 tumors exhibit lower sensitivity to multiple chemotherapy agents in vitro. So to identify effective treatment capable of inhibiting ampullary cancer, particularly those targeting the C1 molecular subtype, we discovered that the multi-target, a smaller inhibitor, sorafenib, significantly suppress C1 tumors organoid in vitro. So sorafenib has demonstrated potent anti-tumor efficacy in pancreatic neuroendocrine tumors. In 2022, we initiated an investigator-initiated trial to evaluate sorafenib combined with CAPOX chemotherapy for advanced ampullary cancer. As of December 2024, 17 patients has been enrolled with our retrospective analysis confirming that 12 of them patients harbored C1 tumors features characterized by a high EMT signature. The preliminary data indicate that an ORR of 41.2%, but there's no completed response case observed, and a disease control rate of 70.5%. So here's my conclusion. We propose to distinguish molecular subtypes with significantly different on survival prognosis and chemotherapy responses. This work offers novel insights into the mechanism driving tumor genesis in the two subtypes of ampullary carcinoma and presented potent potential therapeutic targets based on transcription data. So democratic tumor environment featured as EMT phenotype contribute to the poor survival, which should be highlighted in histological subtyping and clinical treatment. So here's my presentation. Thank you for your attention. I sincerely hope to receive guidance and valuable feedback from all the distinguished experts present here. Thank you.
This very nicely presented paper is open for discussion. Dr. Wolfgang.
Dr. Lin, that was superb. As always, you present an excellent presentation, and I congratulate you on this wonderful, very basic science work. I mean, not only does your group lead in actually in surgery, but also in the research, and so you should be congratulated. When you divided these first two groups, and you may have said this, so you used unsupervised clustering and identified two subtypes. I guess this is an intestinal type and then a basal type. Is the basal type, do these correlate with the histologic intestinal and pancreaticobiliary type, or is this separate from that? Is there a complete concordance between those groups?
Yeah, thank you for your question. So in fact, we do observe the more proportion of the basal-like tumors are features of pancreaticobiliary type.
Yeah.
They may overlap. I think 50 to 80% of pancreaticobiliary subtypes are basal-like tumor.
But that's really interesting. Although there's some overlap, it's not 100%. So it would suggest that if you validate this, that the treatment guidelines where we now use histopathologic intestinal versus pancreaticobiliary may correlate better with this subclassification than the classic histological subtype. So that'll be interesting. The second thing then is about usually things are not dichotomous. So you have two groups, and in the supervised, unsupervised clustering, you give parameters that allow to look for differences. If you loosen those parameters or you do supervised clustering, is there a blend or a sort of another category where you have a mixture of the intestinal and the basal subtype, or are they really very, very different where there's no overlap between the two subtypes?
Mm.
I mean, it may not be known, it may not have been studied, but it's just, and they're clearly, you've demonstrated two subtypes as you do more and more work in this, just as with the Bailey classification, Collison classification, and pancreatic cancer, as you further analyze it, you realize it's not like a straight line in dividing these things, and often the subtypes will move a little bit and potentially eliminating subtypes and developing new subtypes. I was just wondering if you found anything in between a basal subtype and an intestinal subtype that really doesn't fit well in any category, suggesting that there's a blend between the two in some patients.
I agree with you. I totally agree with you.
I did have one question. I mean, I think Dr. Wolfgang is kind of getting at this. I mean, obviously the goal here is to develop a better method of classifying the ampullary cancers so that we might pick chemotherapy more effectively. Do you have any evidence that that is happening? I mean, you report the response rates here and they sound good, but have you compared them to what you all do as more standard practice in making the decisions about how you treat these patients to see that this gives you a better response rate than traditional methods? The other question I would have is just, we tend to do, and in situations where we have refractory cases, we do NGS and look for targeted therapies that might help them. Have you compared this methodology to sort of NGS that's available in different labs across the country? Does that make sense?
You mean?
Is it better? Do you feel just?
No, based on our data, I conclude that it's better using genomic or gene expression data to choose which therapy regions the patient should receive, because we don't have the prospective data to support. So it's just based on our retrospective analysis. So we hope, just like the SPF 4 or 6 or 7, use the molecular subtype to guide the different region, maybe for the ampullary cancer. One day we may use the genomic data to use precision oncology. Yeah.
Thanks very much.
Great. Thank you. I just want to note that that last paper was best paper eligible paper. So our next paper is going to be presented by Dr. Napoli from University of Pisa. It's robotic versus laparoscopic spleen preserving distal pancreatectomy, a propensity score matched intention to treat analysis from the IGO MIPS registry.
Thank you. I'm glad to be here presenting our comparison between robotic and laparoscopic approach for spleen preserving distal pancreatectomy by using data from the Italian National Registry for minimally invasive pancreatic resection. That is an intention to treat registry. So we analyze patients scheduled for spleen preserving distal pancreatectomy, and we divided into two groups, robotic and laparoscopic one, with a propensity score matching. And we analyze as a primary endpoint deviation from planned procedure, conversion to open has intraoperative factors, and severe postoperative complication and 90-day mortality as postoperative factors. We analyze 132 laparoscopic resection and 138 robotic resection, as you can see here. Robotic approach increased over time in our registry, as you can see in this chart. And after the matching, after the propensity score matching, the population characteristic were similar between the two groups. As you can see here, but there was a difference in terms of center volume and surgical experience, with an higher proportion of patient underwent a robotic approach in center with volume greater than 50 pancreatic resection for here, and surgical experience greater than 28 procedure, as you can see here. So we performed a sensitivity analysis with another propensity score matching analysis in order to balance also these features, as you can see here. Regarding the results, intraoperative results were similar between the two groups, except for the usage of stapler for sectioning the pancreas, that is higher in the laparoscopic group respect robotic group. Regarding the postoperative course, there were no differences in our registry, except for the rate of uneventful course that is higher for robotic group respect than laparoscopic group, as you can see here. Pathological findings were similar between the two groups. Regarding the factor related with the shift to distal pancreatectomy with splenectomy, the only independent factor associated with this factor was pancreatic ductal adenocarcinoma, for sure. And the only factor associated with conversion to open was his score greater than 2. Regarding the postoperative course, the only factor that are related to the severe postoperative complication development and mortality were the volume center and surgical experience, but not in a statistical manner, as you can see here. So in conclusion, our analysis highlights that pathology, his classes, center volume and surgery expertise are more critical determinants of intraoperative and postoperative complication outcomes in spleen-preserving distal pancreatectomy respect than the choice of robotic or laparoscopic approach. Thank you.
That's a great presentation. Usually,
Would you mind just telling us who you are?
Yeah, sorry, Greg Sachs, NYU. Usually when we use propensity score matching, we're trying to overcome some kind of selection bias.
Yeah.
So I'm wondering what bias it was that you were anticipating. Was it that one approach, the operation robotic or laparoscopic, was going to more likely be used on more difficult cases, sicker patients? What was it that you were trying to overcome? And just to finish the question, what prevented you from just doing a head-to-head comparison without doing the propensity score adjustment?
Definitely, as you can noted from the chart of the preoperative characteristic, they were balanced well also between the propensity score matching, as you can see here. But as you can see in this chart, the standardized mean difference between before and after propensity score matching decrease after the matching. So probably the only thing that was not matched between the propensity score was this one. So the volume and the surgical experience, because when the volume of the center and the surgical experience of the surgeon increase in our registry, there was a tendency to use the robotic approach to perform the operation respect and laparoscopic one. So we perform this comparison with propensity score match for this reason.
I'm going to go to Dr. Pitt first. Sorry, Dr. Kendrick. Dr. Pitt.
Age before beauty.
He'll
Henry
yell at me.
Pitt, Rutgers. I may have missed it, but did you look at vessel preservation? Because obviously splenic preservation can be done with and without the Warshaw technique or preserving the vessels, and it probably does make a difference. Do you have
Yeah.
those data, and what have they shown?
Yeah, that's a good point. Unfortunately, we have not data for all patients regarding the technique, especially Warshaw or Kimura technique. So it is impossible a good comparison between these this feature. We analyzed that and there was no difference between a robotic and laparoscopic approach, but it's not,
Yeah, there
I'm
may
not
be
sure
more of a
about
difference
that.
between vessel preserving and not than
Yeah.
between this robot or that laparoscopic.
So that was kind of my question too. And since you're here, and we're very grateful that you're here coming from so far away. I mean, what is your approach? I mean, because when I was a laparoscopist and then converted to the robot because everybody was so excited about the robot. And in making that conversion, I found that it was a lot easier to save splenic artery and vein robotically for me.
Yeah.
You know, you're looking at Superman over here on my left, but it was easier for me to save them robotically than laparoscopically. So I went from a Warshaw person to basically trying to save the artery and vein every single time. Or how do you all approach it? Is that what you try to do with both laparoscopic and robotic?
We try to preserve splenic vessel in all our procedure. The availability of robotic system in our center is limited. Generally, we try to use the robot to perform robotic pancreatic duodenectomy, but a lot of spleen preserving distal pancreatectomy were performed laparoscopically. But for sure, if I think that is more easier to perform the preservation of the vessel, the ligation of the branches with the robotic respect to the laparoscopic one.
You left your cape in Minnesota.
One thing you left out that I didn't see was a time bias. Dr. Baker just made the point exactly what I was going to ask, and that is when you're comparing lap versus robotic, you can't say there's a difference unless you know the time bias, because if you start out laparoscopic and you practice 50 times laparoscopic and then you go to robotic, you're going to be better than your first 50 laparoscopic anyway, regardless of whether it's still lap or it's robotic. So did you look at the difference in time, or the surgeons, did they all bail from lap to robotic and now you're practicing you're comparing their learning curve essentially?
This is a good point. In our registry, there was an increase in robotic cases respect to laparoscopic one in all procedure during the time. So this is a good point. Unfortunately, probably we should to repeat this analysis excluding the learning curve, but I didn't do that for now.
Fine, thank you.
I was just going to make a comment, and I guess also a question. That was spoken like a laparoscopic surgeon, and that I would also say that a lot of people used robotic distal pancreatectomy as their sort of learning curve on how to use the robot. So, I think the, kind of argument goes in different directions. And I was just going to ask if in your center, is this maybe ever, it sounds like the robot's at limited availability, but is ever used as a platform to sort of learn the robot?
Yeah, we started with performing this procedure laparoscopically, and then we go to robotic procedure. But as I told you, the availability of the robotic system is limited in our sense, so we have to perform this laparoscopically more than robotic one.
Okay.
Great, thank you.
Thank you very much. Nicely done.
Thank you.
Okay. The next paper is Comprehensive Biomarker Analysis, the role of CA19-9 and DUPAN-2 in resectable pancreatic cancer, including Lewis negative phenotypes, presented by Dr. Umuro.
Yes.
Sorry, from Hiroshima University, Japan.
Thank you, Chair. Today, I'd like to talk about comprehensive biomarker analysis using CA19-9 and DUPAN-2 in resectable PDAC. CA19-9 is widely used as a biomarker for PDAC, but it can be produced in individuals who lack the Lewis antigen. CA19-9 is produced by enzyme FUT3, which is encoded by FUT3 gene. DUPAN-2 is a precursor to CA19-9, and when FUT3 is not functioning properly, DUPAN-2 doesn't convert to CA19-9 and remains in the bloodstream. DUPAN-2, which stands for Duke Pancreatic Antigen 2, was originally developed based on research at Duke University in 1983, but is currently not available for clinical use in the United States. In contrast, DUPAN-2 has been covered by health insurance and widely used in Japan since its early development. So the aim of this study was to redefine the concept of biological borderline resectability using both CA19-9 and DUPAN-2 in anatomically resectable PDAC. This is retrospective analysis. Resected PDAC were included and classified into 4 groups based on preoperative biomarker cutoff values. Of 437 resected PDAC, 400 patients were included in the analysis. Of 400 patients, 74% are upon surgery and 26% received neoadjuvant therapy. This is overall survival stratified by the preoperative CA19-9 and DUPAN-2. The both normal group showed a favorable prognosis with 5-year survival rate of 70% and MST of 120 months. The high DUPAN-2 group, high DUPAN only group, shows a poorer prognosis with 5-year OS of 33%. These patients may lack the Lewis antigen and resulting in normal CA19-9 and a high DUPAN-2. In upon surgery cohort, both normal groups showed similarly good prognosis. So upon surgery might be a good option for these patients. In the NUT cohort, the both high group showed an extremely poor prognosis. So surgery may not be appropriate for this group of patients, and switching chemo could be considered. So in conclusion, the combination of preoperative CA19-9 and DUPAN-2 is a strong prognostic tool, enabling refined risk stratification even in Lewis antigen negative patient with resectable PDAC. Thank you for your attention.
This is very nicely presented. I think Alex, you want to ask a question?
So in the US, like you said, we don't use DUPAN-2, but there's been studies saying that CEA or CA125 could be used. What are your thoughts?
We usually measure both CA19-9, DUPAN-2, and CA125. And today, it's complementary biomarker, CA19-9, DUPAN-2. That's why I choose one. But CA and also CA125 is also a useful biomarker for PDAC.
Did you find that in the ones that did not produce the CA19-9, the CEA was elevated.
No, I don't think so.
Or NYU, just a quick question. Here you talk about combinations of DuPan and CA99, but your initial introduction talked about the non-producers. So can you specifically talk about DuPan-2 in the non-producers and what kind of a prognostic role or predictive role would DuPan-2 have in that specific cohort?
Sorry, I can't quite
So you
follow.
talked about the combination CA99 and DuPan-2, but initially you talked about the non-producers, in which case you don't even have the CA99 status, you can't
Yeah.
use it. So for that non-producer cohort, how good is DuPan-2 in prognosticating patients or predicting treatment response? So good is it as a biomarker in that specific cohort that is non-producers?
No, it's really difficult to detect a non-secretor because usually less than 2 is non-secretor, people think, but some people are less converted to CA99, but still it's not functioning properly. So that's why we use a combination.
Let me add one comment. So we also published the usefulness of DuPan-2 for non-secretor, which means we defined this kind of patient as CA99 lower than 2. We also compared the 2 and 5 threshold, and 2 to 5 can be producible. So which means that, so if you put that lower than 2 as a non-secretor, DuPan-2 is very useful. It's a very compatible to the CA99. We put the threshold at the 2000, which means the CA99 500. So you will compare that those 4 cohort. Technically, you will see the same survival curve.
And
My
this is
only other comment is, how can we get our hands on the DuPan-2 antibodies? I've been trying to do that for years now in the US, but there's no availability. So how can we start helping you investigate this in the US?
Yeah, let me add one more comment. So
Yeah.
I'm trying my best to spread DuPan-2, but it's been very hard. I don't want to explain the whole thing, but which is a very, very low issue as the contract between the Japan company and the Duke University and other American company. So we've been through that.
Yeah, it's commercially available in Japan and it's easily measured by the standard equipment in the United States. So you can measure if you have a kit, but it's not FDA approved.
Yeah,
So
we just don't have it here. I've been looking for it for years now, but we can't investigate it in the US.
I did have a couple of questions. I mean, so your survival data seems different than what we would expect to see here. I mean, 120 months for a median survival time
Mhm.
is 10 years.
Mhm.
That's a long time. So I guess the question is, how do you explain that kind of thing? Do you feel like you're picking up people that just have very early stage in the 2 normal category? I mean, it just seems like a long time. The second thing I would ask you is just, when you look at these 2 markers, especially with one of them not being available in the United States, how does this fit into new available technologies like Signatera or ctDNA? Are you using those kinds of things as prognostic tests too?
Yes, we usually use the CT scan, MRI, and the PET scan, and after that, staging lab.
Circulating tumor DNA.
Yes,
testing it.
it's a research,
Okay.
just a research.
And your survival times? feel
Yes,
long. Yeah.
our median survival time for RPDAC is now about 60, that's median survival, and the 5-year overall survival time is around 50
Mhm.
in my institution.
Okay, thanks very much. Nicely presented.
So our next paper is a best paper eligible presentation, and this is from Jordan McKean at University of Florida. And Jordan's going to tell us about enterokinase and its proposed role in post-pancreatectomy hemorrhage.
Okay, thank you for the opportunity to present. Maybe I can figure this out. Oh, this thing? Or- Oh, okay. I have nothing to disclose, except I can't use this. Enterokinase is an intestinal brush border protease that cleaves trypsinogen to trypsin and leads to the activation of many pancreatic zymogens. And while this is thought to happen exclusively in the duodenum, it is unclear the exact range of enterokinase activity in the small bowel. Post-pancreatectomy hemorrhage occurs in 1 to 8% of all pancreatic resections and is a major cause of overall morbidity and mortality. Late post-pancreatectomy hemorrhage, defined as greater than 24 hours after the index operation, is due in part to the erosion of vessels by amylase-rich pancreatic fistulas. Postoperative pancreatic fistula is more common after a distal pancreatectomy than a Whipple. However, post-pancreatectomy hemorrhage happens almost exclusively after Whipples. So we hypothesize that this difference between distal pancreatectomies and Whipples is because enterokinase, which is produced by the reconstructive intestinal limb in the Whipple, drives trypsin activation necessary for pseudoaneurysm formation. And determining the distance to minimal enterokinase production in the jejunum could mitigate this complication. Before designing our study, we completed an initial experiment where we went to the operating room, we procured fresh tissue samples from the small bowel of our Whipple patient, and we completed IHC staining for enterokinase. So the enterokinase stains in brown, and as you can see, it persists beyond the ligament of Treitz, but does get fainter past the ligament of Treitz. So we designed an experiment in which we continued to collect these samples from the operating room, from the duodenum and the small bowel. We collected the proximal duodenum, the ligament of Treitz, and then 10, 20, and 30 centimeters past the ligament of Treitz. Terminal ileum was also collected in separate operations and used as a control. And then we looked at enterokinase mRNA expression and protein kinase activity and quantified this with PCR and an ELISA. This is the results of our PCR. As you can see at the ligament of Treitz, we still have enterokinase mRNA expression, but this does decrease as you move distal to the ligament of Treitz. Terminal ileum is included here, and enterokinase mRNA expression is essentially absent at the terminal ileum. We then looked at the enzyme activity at all of these points and saw again that the enterokinase activity persists at the ligament of Treitz, but does decrease distally. We saw significant differences between the ligament of Treitz and 20 centimeters past, as well as ligament of Treitz and 30 centimeters past, and between 10 centimeters and 30 centimeters past. So while we showed that enterokinase mRNA expression and enzyme activity persists beyond the ligament of Treitz, we wanted to understand what this meant clinically. So we hypothesized that there would be increased immunostaining intensity for enterokinase, as well as shorter lengths of jejunum resected in patients with post-pancreatectomy hemorrhage. To test this hypothesis, we completed a retrospective study analyzing 3 cohorts. These were patients who had Whipples at our institution, a cohort that had no complications, a cohort who had fistulas, and a cohort who had a fistula and a post-pancreatectomy hemorrhage from a pseudoaneurysm. These group had similar fistula risk scores, which minimized the technical aspects of the anastomosis. All of our patients had large ducts, firm glands, and virtually all of these were cancers. Propensity matching was completed between the no complication and fistula group to the fistula and bleeding group. And these were matched on age, sex, and BMI. At our institution, our pathologists always complete a tissue block of the distal most resection margin of the jejunum for a Whipple. So we pulled these tissue blocks and stained them for enterokinase protein abundance using IHC. Because this was a retrospective study, these were not fresh samples, so we could not complete the PCR and the enzyme activity assay. And we also looked at the length of jejunum resected between the cohorts. This is an example of that distal most resection margin of the jejunum that our pathologists have and that we stained for enterokinase. Our pathologists looked at this semi-quantitatively using a grading system for grading the intensity of enterokinase staining. And then we also quantified this using a software called QPath, where we could look at the percent positive enterokinase staining area. When our pathologists looked at this with their grading scale, we did not see a difference in the intensity of staining between the 3 groups. When we looked at it with IHC quantification using QPath, we did see a significant difference between those who just had a fistula and those who had a fistula and bled. So we wanted to take a look at this cohort further. And we expanded this cohort. We expanded both the fistula and bleeding cohort to 30 patients per group. And because of this, we had to then include the intermediate and high risk pancreatico-jejunal anastomoses. And we also propensity matched these folks. When we expanded this cohort and included both the intermediate and high risk individuals, the difference that we previously saw went away, which suggests that there are other factors likely contributing to these outcomes. We did look at the length of jejunum resected and compared that between each of these groups. And again, we did not see a difference in the length resected in the outcome, although I should point out that the median length resected at our institution was 15 centimeters of jejunum, and only 2 individuals even had at least 30 centimeters of jejunum resected. So this test is probably not the best way to look at our hypothesis because our standard of care has not been to resect 30 centimeters of jejunum during a Whipple. We did look at the percent positive enterokinase staining area and the length of jejunum resected and found that with increasing length of resection, we did have a decrease in the percent positive enterokinase staining area. But again, I will point out we only had 2 patients with 30 centimeters resected. So in conclusion, we have shown that enterokinase mRNA and enzyme activity does persist past the ligament of Treitz, but does significantly decrease between 10 and 30 centimeters past. In low-risk patients, there was a significant difference in enterokinase abundance with fistula only and the fistula and post-pancreatectomy hemorrhage group. Our data does support that post-pancreatectomy hemorrhage is multifactorial because when we added those intermediate and high-risk patients, the difference that we saw in the low-risk patients went away. And taken together, our data might suggest resection of greater length of jejunum might mitigate late post-pancreatectomy hemorrhage. Thank you, and I'm happy to take questions.
Nicely presented. I wonder, there's evidence that, the presence of bile may facilitate enterokinase activity with activating trypsin. Did you all look at the correlation with bile leak with your patients?
We didn't, but we probably could. I think we do have that data that we could go back at least retrospectively and take a look and see if there's any correlation there as well.
Yeah, it might be interesting.
Yeah.
To see.
Jordan, this is really cool, nicely presented and really sort of an innovative way to think about this. For years, we've all made the observation that you started with, and we always say, well, it's because of activation by the intestinal content. Nobody's ever demonstrated, and I think that this is really the first step in understanding it and maybe even being able to mitigate these things. But one of the other sort of observations is that when a fistula becomes secondarily infected, I always sleep with one eye open at night because I'm waiting for the pseudoaneurysm. Are there bacteria that actually express enterokinase, or is there any reason why enterokinase would play a role in why a fistula gets secondarily infected is more aggressive than one that is not? And maybe explain a little bit about what Katie was talking about, is our dirty PJ leaks that become infected.
Yeah, that's a really great question. I don't know. I would have to look it up. I think that's an interesting point. We didn't specifically look at whether or not there was any infection, but we have the data, so we could certainly include that and take a look and see if that had anything to do with it, and look at previous papers too and see if anyone has ever written about, enterokinase and bacteria and things like that.
Are there enterokinase inhibitors? Is this like potential for intervention, like irrigating drains with
Right.
enterokinase?
Yes. I did look that up and I did not find any, but if anyone knows, please let me know, but I could not find any.
Great paper, and I love the physiologic basis of your hypothesis. Historically, and I don't know that there's any proof, but for decades and decades, we assumed that the enzymes elaborated by the bacteria are the reason that infected ones end up causing the deleterious effects that they do. I'm wondering, if you take away all of the enterokinase, are you concerned that you'll have induced exocrine insufficiency? And since hemorrhage is so relatively uncommon, is it worth the risk of taking away digestion in the efforts of trying to prevent bleeding?
Right. Yeah, that is a great question. Thank you. We've thought about that, and Some patients who get total pancreatectomies and then get islet cell transplantation, some of those patients don't have any issues with exocrine insufficiency. So that's something to think about. And then also, you know, like you said, the argument is, yes, it does not happen, thankfully, quite as often, this problem. When it does, it's obviously devastating. And if we could not have that happen, I think it would be really great. And yeah.
Same comment. Great study. Really interesting to think about basic physiology. Have you guys measured trypsin in the drain? Have you measured enterokinase in the drain? And have you thought about the idea, you know, the half-life of enterokinase is minutes.
Right.
So when do you think this is getting stimulated? Have you thought further along down the mechanistic pathway?
That is a great question. No, and we have not looked at it in the drains, but you bringing that up is actually making me think that we probably could, and that would be interesting. And yeah, I'm not sure about when exactly this would happen or how quickly it would happen, but that is something that we can think about.
And then the other question I had is relative to your controls. You had controls from different people.
Yeah.
What's the variability in enterokinase expression among a number of different people?
Yeah, that is a great question. You know, the PCR, obviously, in the ELISA that I showed you was obviously grouped patients together that we looked at. And we kind of had a pretty even spread across patients of how things sort of fell off at different points along the small bowel. But yes, that is something that we thought about. Of course, you know, especially even the terminal ileum that we use as a control is coming from a different patient. And maybe there's a world in which we can take a sample of the terminal ileum during a Whipple, although that sounds like a lot to do for a patient. But yeah, that's a good point.
I'm going to channel my inner Neelon and not ask my question. Very nicely done, but I would encourage others to just be a little bit more short in their responses and questions, as we're now a few minutes late. Sorry,
you.
nicely done. The next paper is entitled Superior Mesenteric Plexus Nerve Reconstruction Following SMA Resection or Divestment During Pancreatectomy is Safe and Technically Feasible by there you go, Dr. Marchetti from NYU.
Good afternoon, everyone. Thank you for the presentation and for the opportunity to present our work on behalf of Molly Rudner, who wasn't able to be here today. And I will describe our experience on superior mesenteric plexus nerve reconstruction following pancreatectomy with SMA resection or divestment. So locally advanced pancreatic cancer often involves SMA and perivascular tissue, including nerve tissue. So when we perform pancreatectomy with SMA resection or divestment, also we resect the superior mesenteric plexus nerve, resulting in a severe neurogenic diarrhea that has huge impact on quality of life of this patient. So we hypothesized that immediate reconstruction of the nerve plexus should offer the best chance of regaining neural function and reduce the burden of neurogenic diarrhea. So we designed this study aiming to analyze the safety and feasibility of a novel technique for reconstruction of the superior mesenteric nerve plexus using either autologous or a cryopreserved nerve graft. And this is a pilot single institution prospective analysis, including all patients underwent pancreatectomy with the superior mesenteric nerve tissue reconstruction between January and September 2024. And for the nerve reconstruction, we use autologous ansa cervicalis tissue harvested in the same time we harvest the internal jugular vein for vascular reconstruction, or as alternative, we use cryopreserved allograft. And the nerve reconstruction was performed after the specimen removal and after vascular reconstruction. The nerve graft was anastomized by a microsurgery team They anastomized the nerve tissue by two narrow raphes proximally to the cervic nerve trunk and distally to the superior mesenteric nerve trunk using a 8-hole nylon suture under the microscope. And after the anastomosis, they also apply fibrin glue to reinforce the anastomosis. And the primary endpoint was to identify the incidence of postoperative complication related to the nerve reconstruction. So for the analysis, we included 15 patients. However, in the last month, we applied the same technique in another 10 patients, and 13 of them underwent total pancreatectomy with either SMA reconstruction or divestment, and 2 received pancreatic duodenectomy. So as you can see, the mean operative time for nerve reconstruction was approximately 40 minutes, so not so long. And in 7 patients, we use autologous ansa cervicalis graft, and 8 receive cryopreserved allograft. And the blood loss for the nerve reconstruction was minimal. Regarding postoperative outcomes, non-patient develop postoperative complication or side effect related to the nerve reconstruction, including neck hematoma, dysphagia, dysphonia, surgical site infection, or hypersensitivity reaction. So in conclusion, superior mesenteric plexus reconstruction using these techniques is feasible and safe, and it can be performed without increasing the postoperative burden after pancreatectomy with SMA divestment or resection. And a prospective study to evaluate the long-term outcomes in terms of quality of life of the patient is underway, and the result will be ready soon. Thank you for the attention. First.
Dr. Vollmer.
Yeah.
Time, undoubtedly, most people have some sort of resection of the SMA, not the artery itself. A lot of added time.
Yeah, for the nerve reconstruction, yeah, we need approximately 40 minutes, and these are huge procedures involving vascular resection. So we think that this step doesn't have a lot compared to the overall operative time.
I'm pretty loud anyway. Yeah, I thought this is really neat. My question is the ansa cervicalis is a tiny nerve. You know, it innervates the strap muscles, the sternohyoid and sternothyroid muscles. So is there another bigger nerve in the body that I'm sure your nerve experts have researched the entire body from head to toe looking for a bigger nerve? And then secondly, you'll really have to be able to study motility, because the nerve, as everyone knows, is a brake in the midgut, not a gas pedal, and you take the brake away and everything goes really quick. So you would need to be able to study motility in some way months later to show a difference. But those would be my 2 questions. Really a neat thought.
Yeah, exactly. So for the first question, we used to use as autologous graft the cervic axis, because yeah, it's in the same point where we harvest the internal jugular graft for vein or arterial reconstruction. And for the second, yes, we will we are collecting data on long-term outcomes, and so we will have this data soon, and we will present soon this data.
Yeah, great answers. Just to follow up on that, we have discussed that. I mean, ansa cervicalis is a relatively small nerve. We have no idea if this is going to work or not. It's sort of interesting idea, but we wouldn't want to go to the extent where we're making more incisions or harvesting other nerves. It's there, we sort of test feasibility. And the cryopreserved nerves that we use are much larger, but of course they're cryopreserved and they're allografts, how they will behave. If we can ultimately show that there's some sort of efficacy, then we would go to the extent of trying to find, a larger nerve elsewhere to do it. we work with our microvascular plastic surgeons that do flaps all around the body, and there's certainly other nerves that are available. In terms of motility, we discussed, are there some types of tests that we could do to test motility? Again, at the end, in our mind, it's first of all, is there going to be anything functional? It's going to be a long-term study that we're enrolling patients, but they all, in the early postoperative period, as you would expect, they all have diarrhea. We're going to see if we can trim any time off the development or the resolution of the diarrhea and look at nutritional factors.
So Dr. Wolfgang, before you sit down, I mean, this is a short presentation, so we were already 4.5 minutes over. And Dr. Zay, I don't want you to go anywhere because I really respect your opinion and I want to hear your question. But I want to know, does it work? I mean, you've done it in 17, 18 patients. Can you tell?
It's hard to know.
Can't tell.
It's hard to know.
I appreciate you saying that.
Really provocative. My only question is the oncologic. I mean, there's so much data out there right now on neurotropic pancreas cancer. If you have a few rogue cells, of course, you get negative margins all the time. I may not. And, that's going to be unanswerable based on the number of patients, but that's the only concern.
Yeah, we discussed it. I mean, one of the things that we're more concerned, we'll follow local patterns of recurrence too, is that we're dividing nerves anyhow. And so, but are we setting up an inflammatory milieu? And it's possible. So, and we will look at local pattern recurrence.
Great discussion. Nice presentation. Thanks.
Thank you.
So our next paper is another best paper eligible presentation. It's post-pancreatectomy acute pancreatitis, a first national database perspective from Andrew Thien at Indiana University.
Close.
Close.
Thank you for the opportunity to present today. My name is Andrew Ten, and on behalf of the IU Pancreas Group, I'm excited to discuss our work, post-pancreatectomy acute pancreatitis, a first national database perspective. We believe that PPAP is an important and emerging entity in the world of pancreatic surgery. I have no disclosures. To start, a brief background about post-pancreatectomy acute pancreatitis, or PPAP. This slide highlights some of our initial work. PPAP has been reported over the past 20 years in literature, and during this time, there's been about 75 unique works that have been produced. These publications have spanned the globe and come from 22 different countries and from even more individual institutions within each country. This heat map here represents countries with publications directly addressing PPAP. This widespread discussion has historically been dominated by single institution studies, resulting in many heterogeneous definitions to characterize a condition. In 2016, Professor Connor published a manuscript offering one of the first collated definitions of PPAP. Then in 2022, the International Study Group for Pancreatic Surgery gave a formal definition. This definition requires 48 hours of elevated postoperative serum amylase, and it's broken into 3 different grades. The first grade, postoperative hyperamylasemia, or POH, is 48 hours of elevated serum amylase postoperatively with no clinical impact, a biochemical finding only. Grades B and C require radiographic confirmation postoperatively and a change in clinical management, with grade C being the most severe, requiring organ failure, reoperation, or death. This definition mirrors the well-known ISGPS definition for post-op pancreatic fistula. A year after the ISGPS's definition, in 2023, the ACS NISQUIP pancreatectomy targeted dataset introduced for the first time PPAP-focused variables. This data became available late last year, and this provided an exciting new opportunity to investigate PPAP utilizing a large national data set. We aim to analyze this first national level data, hypothesizing that this large database would have an incidence similar to previous published single institution investigations. To investigate our hypothesis, we utilized a NISQUIP pancreatectomy dataset that included information from patients from 168 different hospitals. We started with 8,015 different patients, then removed any with missing outcome variables or CPT codes that did not align with a head or tail resection. After this, 7,361 patients were assessed for the presence of postoperative serum amylase. Finally, we used the validated NISQUIP reported outcome variables to better understand this cohort of patients. Our next 4 slides will show you the results. The first observation was somewhat surprising, but important. In the total group, only 17% actually had postoperative serum amylase measured. This slide here shows the incidence of PPAP at the United States national level. The y-axis is a percentage of patients with serum amylase values, and the x-axis shows 4 groups: those without serum amylase elevation, POH, grade B, and grade C. The red bar shows all patients with serum amylase, the blue bar pancreatic head resections, and the gold bar tail resections. Overall, about 1/3 of patients had POH. And then you can see the smaller percentages of patients with clinically relevant PPAP, or grades B and C. In general, patients with pancreatic head resections had higher incidences of all categories of PPAP than those with tail resections. This national level data reflects the incidence of POH and PPAP to single institutions. This slide here shows the influence of PPAP on patient outcomes. On the left side of the chart, the columns on the left side of the chart are the outcomes, and the columns indicate POH and clinically relevant PPAP, or groups grades B and C grouped together, for pancreatic head and tail resections. POH and PPAP patients had significantly higher incidence of complications, including post-op pancreatic fistula, morbidity, and readmission. Notably, POH or clinically relevant PPAP did not have any significant influence on mortality of any of these groups. Interesting, patients with pancreatic tail resections had POH decrease, and POH had a decreased incidence of any post-op pancreatic fistula, but an increase in clinically relevant. An important part of the ISGPS definition is the imaging confirmation of pancreatitis. However, at this point, it continues to be debated among authorities. This slide here shows the outcomes with and without confirmatory imaging. Among all patients with elevated serum amylase, 41% had CT scans. In this group, 70% had POH and 30% had clinically relevant PPAP. 59% of patients with elevated serum amylase did not have an identified CT scan. In this group, 18% had clavien dindo greater than 3 complications or death, equivalent to the clinically relevant PPAP. These data highlight several important findings. First, only 17% of the US pancreatectomy patients had serum amylase measured in the postoperative period. This finding highlights further effort and investigational work needed, something I will tell you about in a minute. Secondly, the US national incidence of POH and PPAP mirrors previous institutional studies. Third, both POH and PPAP are associated with worse clinical outcomes. And finally, a point I hope we can discuss further is the utilization of CT scans in the United States are selectively utilized for patients with postoperative serum amylase. I would like to take a moment to highlight our future direction, which is qualitatively evaluate the thoughts of pancreatic surgeons about PPAP due to this relatively low number finding. If you'd be kind enough to participate in the short survey, we would be grateful. And I thank all of you for your attention and would be happy to take any questions on this subject.
Very nicely done, Dr. Pitt.
Great talk. I'm Zhenjian Lin from Nanjing Pancreas Center. And for PPAP, our center, in nearly 2 years, we routine examined the serum amylase after the first or second day of a post-operation. So I found that 90% to maybe 90% patients don't have elevation or a slight elevation, but they don't have any sign of PPAP. And my question is, can we more precisely to target which patient should test the amylases? Because everybody tests is a waste, and the incidence of PPAP is relatively low. And then the most important is that we should find who the patient who need presumed or timely treatment to decrease the mortality. Thank you.
Yeah, so I believe your question is there a certain group of patients that we should focus on ordering our post-op serum amylase? I think a lot of the literature has shown what was discussed earlier, talking about fistula risk scores, that in patients with higher risk fistula risk scores, there's been higher incidences of PPAP, something that we plan to investigate in this study. So I think if you really had to tailor on one specific group of patients you wanted, that would be a good start. But I caution against that. To get a better understanding of this new and emerging entity, I really think that postoperative serum amylase should be measured on all of our patients so that we have a better understanding and we can identify in large data sets those who are truly at risk for those who are not.
As a clinical observation, I noticed that patients may have the sign of the heart rate increase, or they complain about their pain in the abdominal. So what's the patient's symptom in decision? The value of patient symptom or their complaint will influence your your choice to take any examination or CT scan to exclude PPAP happen.
Sorry, I'm having a hard time hearing. I can't hear very well.
I mean that the clinical symptom or patient complaint. will-
Basically, they don't have any symptoms different than the early post-op, day or two.
Yes, yeah. In my understanding, a lot of the patients, it's a clinically different, difficult entity to tell from patient symptoms due to the normal pain after a postoperative, after a resection. And so that could be a difficult way to tell.
So Henry Pitt Rutgers, thank you for bringing this to everybody's attention. When we built this metric into NSQIP, we tried to mirror exactly what the International Study Group said had to be done. And it's really difficult because you need 2 serum amylases within the first 48 hours, and then you need a CAT scan to be done within the first week or so. So in a way, it's not surprising that we have very little data. And that's part of, I think, what we're asking the audience. Please start measuring the serum amylase, routinely post-op in the first couple of days. And if it is elevated, please do CAT scans relatively early on, like the Dutch did with the Porsche trial, and they were able to reduce their overall mortality. And I've actually seen some of the data which are a little bit more recent, and we're not a whole lot better now than we were then in terms of that 17%. So it's more of a comment to the audience. Please start looking for this.
Ingmar Rompen, Heidelberg University. The first question is, it was only measured in 17% or only reported in 17% in the NSQIP? And probably the more important question is, we struggle a lot in deciding who we take back to the OR and perform total pancreatectomy, because when we wait too long, it's a mess in the OR. They have necrotic pancreatitis sometimes, and those have a high mortality. So what are your decision steps in whom you take back to the OR and reoperate on?
Yeah, thank you for your question. For the first question, I do know that that's a valid concern. The NSQIP data set has its variables taken by trained clinical reviewers who are trained in finding the different variables, but there is always a possibility that variables are missed. In NSQIP, the reviewers are supposed to look for 2 elevations above 48 hours. But only the highest elevation is reported, which does lead to some possibilities. Are they always finding 2, or are they just finding 1? In regards to your second question about what do we look for to decide who we take back for the operating room, I think that's a challenging question. Everybody has the signs or the clinical symptoms that they think are the most heralding for an urgent situation or somebody who really needs that total pancreatectomy. I don't have a finite or a hard point to suggest in my experience as a trainee. I think it's an overall clinical picture that really decides which ones you have to take back. And I don't know if there's a certain time point or a scan that will show that.
I think this is really an important paper, very well represented. Unfortunately, we do know that there's a subset of patients in all of our careers with an unexplained hyperamylasemia and not even a bit sick. And in those patients, you just say, ignore it. They're not sick. And so I worry as you're overlapping, there's a shaded area because, and as Henry already mentioned, normal post-op recovery after a Whipple can look a lot like pancreatitis. You have pain, you have sequestration of fluid, you can have tachycardia, you can have all those things. But it is a teaching point if you have that to say, now I better look and see if I have an unexplained an unrecognized acute pancreatitis versus doing an amylase on everyone, and then potentially in some places overreacting and thinking you're going to reoperate on someone based only on the fact that they have a hyperamylasemia.
Yes, thank you. I think that's a very good clinical point.
Nice job. Thanks. Okay, the next paper is entitled Frailty as a Predictive Marker in Acute Pancreatitis, presented by Dr. Gupta. Dr. Gupta, yes, Postgraduate Institute of Medical Education and Research.
Thank you. Thank you, Pancreas Club, for this opportunity of podium. So we looked at sarcopenia in patients of acute necrotizing pancreatitis. There are no financial disclosures. Acute necrotizing pancreatitis often causes systemic inflammatory response with hypermetabolism and multi-organ dysfunction. The traditional markers which are used are CRP, BICEP, Apache-2, and CTSI. However, they are not good enough to look at the dynamic monitoring and the physiological assessment. Sarcopenia, on the other hand, reflects nutritional status, immune competence, as well as physiological resilience. And its potential in acute necrotizing pancreatitis has remained largely unexplored. So we designed this study over a 2 years period from January 22 to 24, included all patients above 18 years with necrotizing pancreatitis. We excluded patients with diseases which could affect muscle mass. We measured psoas muscle index at L3 vertebra, and there were gender-specific thresholds, and these measurements were done at admission at 1 month and then 6 months at the time of discharge, after discharge. So we looked at the relationship of sarcopenia with mortality, with ICU or hospital stay, secondary complications, and we analyzed this data using area under curve and multivariate regression analysis. We found that 46% of the patient had initial sarcopenia at admission, which increased to 47% at 1 month and then decreased to 39% at 6 months. Mortality rate in patients who had sarcopenia was significantly higher, 38 versus 9.1%. Similarly, the ICU duration was also higher, 22.4 days compared to 14.6 days in those who did not have sarcopenia. And area under curve was 0.81. It outperformed CRP levels and BICEP. And this is a comparative analysis which shows sarcopenia faring better. And we found that sarcopenia reflects physiological changes complementing static marker like CTSI. Routine CT-based assessment should be incorporated into the ANP management. Based on this study, we think so. And it has a better accuracy for mortality and complications than traditional markers. Sarcopenia is a robust predictor of ANP outcomes according to our results, and this study is done earlier. It addresses both anatomic and physiological dimensions and should be incorporated into routine ANP assessment. Thank you. I'm happy to take any questions.
Very nicely presented, Dr. Hardaker.
Thank you for that presentation. I'm curious, how did you account for patients who were initially admitted to an outside hospital, maybe there for a couple of weeks, and then transferred to your facility? Was the admission sarcopenia measurement at the outside hospital or your hospital?
It's a very good question, and that's what has been, the problem with this study as well. Most of ours is a tertiary care center, and most of the patients are referred patients. So, the at admission sarcopenia does not reflect the true sarcopenia in the population. So these patients to begin with may not had sarcopenia, but because in the previous 2 to 3 weeks period, they were admitted somewhere else, and it was not measured. So, we do not have that information. However, at time of admission, we looked at all these patients.
Thank you.
Great study, Juan Gurria from Cincinnati Children's. Do you look by any chance at the chronicity of their pancreatitis, or is this just a one-time acute necrotizing pancreatitis? The reason why I'm asking is I deal with a different cohort of patients with acute, recurrent, or chronic pancreatitis in children, and we've seen the sarcopenia correlates directly with their chronicity of disease.
So that's a good question. The one part is that these were all acute necrotizing pancreatitis, which was the first instance. We did not have any patient with recurrent acute pancreatitis. But the other thing is, significant proportion of these patients had alcoholism. So probably that was also contributing to sarcopenia in this subset of patients.
Thank you.
I had one question for you. I mean, I feel like with the sarcopenia problem, you sort of inherit it. It's what you're dealing with at the outset of the pancreatitis. Are you using it to guide treatment at all? I mean, it's a prognostic factor, sure, but what can you do about it?
Well, if these patients come early to us and we, at the time of admission, know that these patients have sarcopenia, then some of these patients who do not have sarcopenia but pancreatic necrosis, we may not actually do step-up approach and may do definitive upfront surgery. But most of these patients, because of the delay in presentation to our department, have sarcopenia at time of presentations. So we have to institute step-up approach, wait for these patients to come back to some sort of recovery in their functional reserve, and then take up the next step. Which, if we know upfront that, at the time of admission, this approach can be utilized.
Thanks very much.
Thank you.
Great, thank you. Our next paper is Advancing Pancreatic Cancer Resectability Insights from 1,251 Vascular Resections in 812 Patients at a Single Center. Presented again by Dr. Napoli from PISA. Thank you.
Good afternoon. Thank you for the opportunity to present this work. In this presentation, I will present our experience regarding vascular resection during pancreatectomy in PISA. We evaluated over 1,200 vascular resection performed during pancreatic resection during near 40 years of experience at a single center in Pisa, in Italy. We analyzed all our patients and divided it into three eras. Era 1 from 1986 to 2012, Era 2 from 2013 and 2019, and Era 3 from 2020 and 2024. We analyze more than 500 vein-only resection, more than 200 combined arterial and vein resection, and more than 100 SMA resection. We analyze how these different fields changed over time during our experience, starting from patient selection. As you can see from this chart, his score rate has increased over time regarding his score greater than 2 and his score 4. But with a decrease regarding chronic heart failure rate and chronic obstructive pulmonary disease rate in our patient during time. But regarding arterial resection, heart failure rate, chronic obstructive pulmonary disease rate, diabetes rate decrease over time. And even if the ASA score greater than 2 rate increased over time, the median age and the rate of ASA 4 was similar during all our experience for arterial resection. For venous resection, even if heart failure and chronic obstructive pulmonary disease remain stable during the whole series. But the median age, the hypertension rate, the diabetes rate, the HESA score greater than 2 and HESA score 4 have increased over time for venous resection. If we take a look at the last period, the patient underwent vein-only resection, had a higher median age and were more frequent associated with chronic heart failure, hypertension, diabetes, and as a score greater than 2. Respect artery resection. And this is an important factor that highlighted the importance of selectioning of these patients regarding arterial resection in order to improve our results. Regarding the indication, cholangiocarcinoma has decreased, rate has decreased over time. While pancreatic ductal adenocarcinoma rate has increased over time, probably reflecting the introduction of effective neoadjuvant chemotherapy protocol and guidelines for pancreatic ductal adenocarcinoma. Reaching around 90% of patients during the last period. The introduction of effective neoadjuvant chemotherapy protocol for sure affected also the rate of preoperative chemotherapy and the rate of preoperative radiotherapy that have increased over time during all the period. And has reached around 90% for arterial resection in the last period, as you can see from this chart. Regarding the intraoperative outcomes, the first thing that stands out from our series is that the complexity of the surgical procedure has increased over time, with a reduction in the rate of vein-only resection and increase in the rate of combined arterial and venous resection and SMA resection, as you can see here during the experience. And moreover, has increased the median number of resected vessels per patient and the median number of SMA branches resected for patients, as you can see here. Regarding the approach, there has been an increase in minimal invasive adoption during these 3 periods, as you can see here. And there has been also a change in the type of procedure that we performed, especially with an increase in the rate of total pancreatectomy and a decrease in the rate of pancreatic duodenectomy, especially for arterial resection, as you can see here. Regarding the reconstruction, we experienced a higher rate of type 3 vein reconstruction, respect type 4 vein reconstruction, thanks to an extended cut-off brush maneuver that allowed us to avoid the usage of jump graft for the vein reconstruction. Regarding SMA reconstruction, there has been a reduction in the rate of end-to-end reconstruction with an increase in the splenic artery rotation, in the anastomosis to gastroduodenal artery stump, and especially in the hand-to-side splenic artery reconstruction, especially for the fact that in the last period we started to reconstruct a higher rate of multiple branches for the SMA, and a lot of them we reconstructed on these in a hand-to-side anastomosis to splenic artery. Regarding the celiac trunk hepatic artery resection, we experienced an increased rate of the reconstruction over time, as you can see here, especially with the use of a jump graft, as you can see from this chart. During the procedure and during this period, we experienced a reduction in the splenectomy rate, especially in total pancreatectomy, especially in total pancreatectomy with arterial resection, where the splenectomy is not due to tumor factor, for sure. Also, total gastrectomy rate has decreased over time overall, but also more for total pancreatectomy with celiac trunk hepatic artery resection, and even more for total pancreatectomy with celiac trunk hepatic artery resection and superior mesenteric artery resection. And also the rate of colectomy has decreased over time, especially for arterial resection, as you can see here. And even if the complexity of our procedure increase over time, the results remain stable with a reduction for grade 3B postoperative complication for arterial resection, an increase of grade 2 postoperative complication, but the rate of postoperative deaths and grade and severe postoperative complication and failure to rescue remain stable during the 3 periods. And if we consider only the last period, we experienced the same results for vein resection and artery resection alone, as you can see here. And moreover, there has been a reduction in the postoperative deaths and in failure to rescue during the 3 period for SMA resection, a reduction in post-pancreatectomy hemorrhagia and in intestinal perforation rates for arterial resection over time, as you can see here. Regarding pathological finding, the R1 rate has increased over time for sure after the introduction of a new definition of a positive margin after 2009. Also, the harvested lymph nodes number has increased over time, as you can see here. Regarding vascular infiltration at the pathological examination, these features remain stable during the 3 period, but the vascular infiltration behind adventitia for arterial resection decreased over time, as you can see here, both for SMA and celiac trunk hepatic artery resection. Regarding long-term survival, the overall survival has increased over time, both for arterial resection and venous resection. For sure, the contribution of preoperative chemotherapy was important, but also the technical improvements during the operation and during the postoperative curve, course has contributed to enhance these long-term results, as you can see from this multivariate Cox regression. So, in conclusion, this study shows us has improvement in the selection of the patient, in multimodal therapies, in technical innovation, has allowed us to refine our result in vascular resection during pancreatectomy. We were unable to manage even more complex cases while verifying the potential survival benefit of prognosis based the resectability in well-selected patients. Thank you.
Really, no questions. I mean, this is an unbelievable experience. I'll say that. And I'm kind of surprised, given the people that are in the audience, and Dr. Evans was the one I was wondering the most about, that there weren't more questions immediately.
Yeah, really an incredible experience. A tremendous amount to unpack here, no doubt. But one of the things when we're looking at someone and thinking about a big operation, we obviously look at the comorbidities of the patient, how big the operation is, and then I think in the current era, how well they have responded to induction therapy. So perhaps something that you may want to look at in the future, because whenever we have an outcome that isn't good, and nowadays with the ability to keep patients alive, it's hardly ever that someone dies within the first week or two of surgery, but certainly a big operation, and then the cancer come back within 12 to 18 months is kind of a crummy result. And one thing that might be helpful is to look back at your experience with vascular resection and say, well, in retrospect, which of the patients should we maybe not have operated on? And could we use response to induction therapy as also a guide to who gets a big operation? And then just one comment that you mentioned, the Cattell-Brash maneuver and mobilization of the midgut. I would just caution, especially maybe the younger surgeons in the room, about trying to bridge a gap by releasing the midgut. The venous system, as people who are a little older in the room know, is rather unforgiving. If you have too much tension, it's going to occlude. And certainly if you've mobilized, one of the things I try not to do is to, if I'm going to do an interposition graft and I can avoid mobilizing the whole midgut, it's nice because then you don't have any risk of a twist. But wonderful presentation, tremendous experience.
Thank you. Regarding the result, tomorrow we will present a study of our multicenter research group called Rediscover, in which we presented that the surgical resection in selected patients outperform the oncological results regarding long-term survival. So it's true that comment, but I think that surgical procedure after neoadjuvant chemotherapy should be performed in this type of patient, and is a key for a long-term survival as the preoperative chemotherapy too. Regarding the mobilization, we used to perform direct anastomosis for the vein resection, avoiding jump graft, but in a lot of cases, in some cases we use it, especially during a minimally invasive approach. But thanks for your comment.
Dr. Wolfgang.
Yeah, amazing experience and nice presentation. I think some of my questions are a little bit of a follow-up on what Dr. Evans was talking about. So in the period that in your cohort where there was use of sort of multi-agent modern neoadjuvant chemotherapy, is there, when you look at your data, is there an inflection point in terms of response in people who had long-term survival? Is there a certain amount of neoadjuvant that is sort of optimal, or do you titrate toward response? Is there a minimum amount of neoadjuvant in these complex operations? Yeah. And then just a clarification in the one, if I saw it correctly, about 10% of the arterial resections had gotten no neoadjuvant. I assume that those were just incidental findings at the time of surgery where you found arterial involvement, or is there a cohort in which you go directly to surgery?
Thank you for your question. Regarding the first one, we analyzed the long-term survival during the treat period and also after the 2012 and the introduction of the effective neoadjuvant chemotherapy protocol, we experienced an increase in the long-term survival. Not only with a shift from era 2 to era 3, and not in this study, but in another study, I highlighted that also the amount of chemotherapy is an important key factor for long-term survival, both for vein resection and arterial resection. It's very important that the patient completed all the chemotherapy, so 12 cycle, especially for arterial resection for me.
I mean, that was pretty much it. It sounds like tomorrow's talk will have maybe answer some of my other questions. It was more about the sort of long-term outcomes in patient selection.
If I may add something, Chris, to your question. This is why we should put the data of many centers together, because these are quite large figures. Then when you go to break down by period, by this and by that, you don't have enough data, enough granular data to come to the very important question you are asking that was not even addressed in the rediscover guidelines. Actually, we don't know how many cycles and blah, blah, blah. So this is why you should put the data together. And also commenting on Dr. Evans' question, I agree. There has not to be too much. Cannot see where you're standing there. So we should avoid too much tension on the vein. That's correct. Not just because of the greater tension makes the vein to flatten, and so you lose the caliber of the vein, but also because when you go deep into the root of the mesentery, the wall of the vein becomes very thin, and so to put too much tension in there is an additional reason for potential complications. So these are things that we have learned over time. However, many years ago, we were using a jump graft as a routine, and nowadays we use it selectively. This is the meaning of what we've shown. Thank you.
Sure, you don't want to go first? Yeah. I think it's important, and I think most of us, well, particularly those of us with gray hair, know that we're really in the presence of two absolute pioneers with Dr. Evans and Dr. Boji. And they were doing these arterial resections when it was almost punishable by death. You know, we thought of it as being almost illegal to do a arterial resection, and they did them long before any of us. I was a member of the consensus conference that Ugo Boji planned in September of last year, and I was part of the oversight committee. And to be honest, there was much more enthusiasm for divestment than there was for arterial resection. And if I look at your number 5 checkpoint on the slide that somehow magically disappeared, you mentioned that you only have involvement in the intimate 6% of the resected specimens, and you say maybe this suggests that divestment is a preferable outcome. I still think these pioneers showed us a way that I don't think anyone else was ready to explore.
For sure, we experience around 6% of vascular infiltration beyond the adventitia, so the adventitia plane. So probably in a selected patient, this vestment could be a viable operation respect the resection, but more study are needed to evaluate if this factor infiltrated the overall survival for the resection margin positive rates.
Two very quick questions, if I
Yeah.
may.
One of them needs to be about functional health. If I could ask you to ask that question too, would you mind, just about how the patients do, how they feel, whether or not they regret the decision to have this kind of operation? But go ahead. Sorry, Mike.
No, it's all right. So the first one is, it's not a surprise over the eras where the patients are more complex, right? There are more comorbidities, the ASA scores were higher. As we get more comfortable with vascular resections, it makes sense that we're adding patients that we probably wouldn't have 10 years ago. So can you give us maybe 1 or 2 points of what is resectable and what is not? Because, I mean, we saw an amazing series of resecting pretty much everything but the aorta, and you've probably done that as well. But just maybe an idea of what's resectable in terms of the patient functionality, the the anatomy of the disease. Second thing is I may be the only one that recognized this, but in the last era, the laparoscopic vascular resections actually went up. And I just want to know if Dr. Bogie has finally seen the light and he's coming back to laparoscopy, or why is it more common to have a laparoscopic vascular resection in era 3 versus era 2? Or did I see that wrong?
The laparoscopic approach is more common in the era 3 than era 2, for sure.
I'm not sure. I don't have the figures there to comment on that. So we do minimal invasive vascular resections very selectively. If it is a right-sided tumor, we do it by robot. This is our philosophy. But if it is left-sided, we do it equally. So probably in the last era, we have done more left-sided laparoscopic resections. And then we are also asking about, you meant to go.
Who gets that?
Well, the selection, like Dr. Neal said, could be punishable by that. So the philosophy is that you have a cancer, a nasty one. It's not nasty because it is larger. It is nasty because it is a pancreatic cancer. It's also nasty when it is 5 millimeters. The selection is chemotherapy. Once you have successfully received chemotherapy, it means that you are really doing well. My point is the people must ask me, why are going to operate on myself if I do so well? And the reply is that because you have a pancreatic cancer, but they do really well. This is the C component. Then for the B component, for the moment, at least until we have better markers, the CA99 has to decline very much. The lower, the better. I also write in my first letter, the CA99 has to go down. The most, the better. And the third is that there is no disease progression. If there are no metastasis, then what is the limit? You cannot reconstruct the vein. You cannot reconstruct the vein, not the artery. It is very rare that you cannot reconstruct the artery, but there are a few people with portal cavernomatosis, which really you can't reconstruct a vein. So in a case that you believe it is nasty because of the artery, the limiting factor is often the vein. The other things are basically, I can't reconstruct the vessels. And this is why, for example, if I have a SMA case, I start from the mesenteric root. So I always start from the nasty point to make sure that I can't reconstruct. But by having said that, I never come up with an R2, ever. I don't think that there is space for R2 surgery for that adenocarcinoma. And so the technical limits are few. You mentioned the aorta, I've done once. It was a lady that had a vascular resection, a vein, 13 years before, and eventually she had a local recurrence, the aorta, keeping in there the two renal arteries, the SMA, and the celiac trunk. So why not to do that? 13 years later, no distant metastasis, it becomes a technical issue. So in my view, right now that we have chemotherapy, we've turned something that was prognostically nasty in something that is technically difficult. As surgeon, we should be ready to handle technical difficulty. What we cannot handle is unfavorable biology, but the biology is taken by the chemo, and then the technical part is on us.
Okay, thanks, everybody. Yeah, nice job. The next paper is a biodegradable polymeric sealant applied to transected margin following staple distal pancreatectomy reduces overall complication of randomized controlled trial by Dr. Nika Farjam from Austin Health in Australia.
Thank you very much for allowing me to present our work on behalf of my colleagues in Melbourne and Sydney. I have no disclosures. We all appreciate here that distal pancreatectomy is associated with significant morbidity, and most of that morbidity is related to post-operative pancreatic fistula. Some of the morbidity can be relatively mild, or it can be quite significant, resulting in multi-organ failure and death. Based on systematic reviews, the clinically significant fistula rate is approximately 20%, but probably in a lot of centres that aren't included in these systematic reviews, it may actually be much higher. So we do need to do better. We need to improve the outcomes of this surgery by reducing postoperative pancreatic fistula. The study rationale for this came about when I was here at one of the meetings in 2019, when I saw our Japanese colleagues present their work on a randomized control trial between a reinforced and non-reinforced stapling. At that time, I was utilizing staplers, and my group were using reinforced staplers to reduce pancreatic fistulas. But after that study came, I really questioned the use of reinforced staplers for transecting the pancreas. And subsequent to that study, a few other randomized controlled trials were published showing that reinforcement has no significant benefit unless you look at a very small subgroup of patients. And also associated with that is cost. Reinforced staplers cost about 3 times as much as non-reinforced staplers. So looked at how can we improve a non-reinforced stapled transection. At that point also, I looked at the various different glues that were on the market. I thought that maybe we can apply some kind of sealant to the transected site. But what sealant should one use? There's a myriad of sealants, and looking at the literature, polyethylene glycol-based sealants in some animal studies had shown that they could actually close the pancreatic duct when injected in it, versus glucoaldehyde-based sealants prevented physiological closure, and fibrin-based sealants essentially get broken down by lipase and amylase, and in multi-center studies and in multiple studies have shown to be of no benefit. So looked at a product called Progel, that's a polyethylene and a recombinant serum albumin type based glue that's used for preventing air leaks post pneumonectomy. And this sealant appeared appropriate to test on the transected margins. It costs about $1,500 US, and a version of it is approved in the United States for vascular surgery. Following that, my group and myself decided to look at using this type of glue on transected distal pancreatectomy. And in 16 consecutive patients, we had no clinically significant fistulas, compared to 24% in a subgroup beforehand. And this really set up the pilot study to set up a randomized control trial. Our ethics, unfortunately, would limited the number of patients that we could study, looking to see if we can get a reduction from approximately 25 to 30% down to less than 5%. Whereas we really wanted to look at larger numbers. We were limited to 40 numbers per arm, 35 with 5 just as a safety. And we enrolled patients across multiple centres. 83 were enrolled in total. 5 were excluded because we found advanced disease at the time of surgery. And we ended up with 40 patients in the control group and 38 patients in the polyethylene or PEG group. And they were all followed up completely. Inclusion, we included patients over the age of 18, included patients who had tumours in the tail and body, avoiding tumours that were near the GDA where, you know, the leak rate in those cases is quite hard and a stapled resection is not possible in many of those cases. And we excluded patients with significant renal dysfunction because of the excretion of polyethylene glycol through the kidneys, and those with albumin allergies, and anyone who had a proximal stricture. We use the international criteria to make the assessments. Just to show the technique, this shows transection using a bariatric type graduated stapling device. We stipulated that we would want slow transection of the tissues. We've really moved on since this time to looking at a 10-minute compression time on the pancreas based on some randomized control studies. But in this study, we just stipulated slow transection. The transection line after completion with the stapler, we allowed surgeons to treat with sutures if they thought it was necessary, or diathermy, and this was all recorded. This video was shown to the surgeons to teach them the technique. Afterwards, we applied the Pro-Gel. It comes in 2 syringes that merge together, and it's sprayed onto the pancreas. We make 1 application, wait a minute, and do a second application. The amount applied also, we do apply some over the vessels as well. You'll see that after the second application, it forms quite a firm gel over the surface of the transection line. Any excess sealant can be removed with a suction, as shown here. And it forms a nice firm seal, as you can see. In terms of our patients, there was no difference in the characteristics of the 2 groups. We utilized open and laparoscopic and robotic approaches in approximately 50-50. Splenectomy was performed in the majority of cases. Most of these cases were done for cystic tumors, but approximately 30% were for adenocarcinomas. Portal vein resection and colonic resection wasn't utilized in many cases. Most of them actually ended up in the PEG group. And when we looked at our results, the overall complication rate was significantly less in the polyethylene, the PEG group. And in terms of the grades of fistulas, there was a trend towards significance. Of note, we found that 2 of the patients in the PEG group, they were classified as having B-grade fistulas because of the practice in some centers of sending patients with grade A fistulas home with a drain and bringing them back 4 weeks later to remove the drain. So they were all classified up in those scenarios. And I think that is a limitation of the international guidelines. So these patients were perfectly well, but were classified and kept in that classification. There was 2 postoperative bleeds, and they actually occurred in the control group, and one of which was from the staple line, and that patient actually had a PEG applied on the second operation. In terms of looking at the results, we had also a trend in terms of male gender towards having more fistula. Spleen preservation in this study was significantly associated in univariate and multivariate analysis as increasing the clinically significant fistula. And the PEG group, there's remained a trend in both univariate and multivariate studies. So in this study, the PEG group reduced complications significantly. There was a trend towards lower fistula, but the study was underpowered for in some degree. There was a classification issue that we identified with the international classification and supports larger trials. It is the first randomized control trial using this type of sealant, and it was multi-central, so it's generalizable, seemed safe, and the limitations of the study was the technique of actually stapling, of which staplers are used, and the compression times, and the small sample size. So in conclusion, PEG or polyethylene glycol-based sealant appears to be effective in reducing complications following stapled distal pancreatectomy, with a trend towards less clinically significant fistulas, but larger trials are required. Thank you.
Very nicely presented, and thank you for finishing on time.
Yeah, we're all searching for that miracle to stop these distal pancreas leaks. Don't you think you really needed to scan everyone? Because patients can have fluid collections and be relatively asymptomatic. And since I only take care of cancer, I repeat their scans at restaging at about 6 weeks. And it's a humbling experience to see just all the fluid collections. But the majority of patients are asymptomatic. So if you're only looking for symptoms, it seems like you would just need to have done some form of imaging to look for the fluid leaking out from the pancreas. But what do you think?
I agree. I think there are a lot of the rate of leaks is much higher, but if it's not clinically significant, I guess we're capturing the clinically significant leaks here. But we didn't specifically look at routine imaging. Majority of these patients did get imaging within the first 6 months. So they were followed up for 6 months, but we didn't look into detail of looking at differences there.
Yeah.
Great, thanks very much. Nice job.
Our next paper is from MGH. It's Louisa Baum is presenting in-depth proteomic profiling of ampullary adenocarcinoma, pancreatobiliary intestinal subtype to guide clinical decision-making.
Yeah, thank you so much for the kind introduction, and it's a fantastic honor to present our study here at Pancreas Club. So we're back at the ampullary adenocarcinoma. So as you've heard before, they're quite rare. They're part of this group of periampullary carcinomas. And the only real curative option that we have is complete resection. Overall, their prognosis is quite favorable if we compare them to PDAC, for example. So they are biologically distinct. Histologically, that's what they look like. So we have two major components here. First, the in situ component, that's the proliferating tumor mass, and the invasive component that invades into the surrounding tumor environment. And of course, then we have the tumor environment itself. We've heard that before. We have these two subtypes, and the reason why we have them is because the ampulla is a really heterogeneous location where different epithelia come together, which is one, the intestinal epithelia, and then the epithelia of the biliary tree. So we have two subtypes that resemble their respective histologies, and they're characterized by some markers. We've heard some of them before, mostly used, I think, internationally for the intestinal one is cytokeratin 20 and CDX2 for the pancreaticobiliary more cytokeratin 7. So the aim of our study was to really connect clinical variables with proteomic characterization, a large cohort, and to understand these histopathological subtypes in more depth, because what we've been doing so far is look at morphology and a couple of IHC stain markers and classify them, and to really look into determinants of outcome and how is this connected. So our patient cohort was derived from US, American, and European centers. We matched clinical data with formalin-fixed, paraffin-embedded tumor samples. And that's the first comparison of intestinal versus pancreaticobiliary subtype. For the pancreaticobiliary ones, they're more advanced in stage, they have more involved lymph nodes, and they're more locally infiltrative in terms of lymphovascular invasion and perineural invasion, which translates into impaired overall survival. That's something we know from other studies too. Looking at the proteomic workflow, so we identified the slides locally by the pathologists at the participating sites. They were delineated for the different components, so in situ versus invasive versus tumor environment. And those areas were then macro dissected and entered into our mass spectrometry pipeline. So first results, this is coverage. That's the first thing you look at. And we have an average of more than 7,000 proteins identified per sample. That's really good. And if we perform some unsupervised clustering of the different components, we see that they cluster apart from each other. So we can differentiate them quite well proteomically. Also, when looking at the volcano plots, there's an abundance of proteins that is really differentially regulated between these components. So that is something that we can really clear-cut differentiate. Also, when looking at the independent cohorts and looking at the overlap, we see a really strong overlap for those proteins that differentiate the components. So this is something that's very well reproducible. Looking at it ontologically, what's really different in the pathways that are proteomically represented in these different components. If we compare in situ to invasive, in situ is mostly characterized by pathways that are involved in real basic cell metabolism. So nothing hyper exciting here. Invasive component is more enriched in classical pathways of cell motility, as you'd expect. Looking at in situ versus non-tumor, we have epithelial differentiation pathways. That does make sense. And for the non-tumor, we have a lot of extracellular matrix reorganization pathways. When comparing invasive versus non-tumor, again, we see this upregulation of cell motility. And for the non-tumor component, it's more basic cell metabolism. Now looking at the histopathological subtypes. So they do cluster apart from each other proteomically, but we have quite a large area in between where we have some overlap. And that's not only explained by those mixed subtypes that are clearly identified as having features of both. They do fall into this area, but there is a bigger area than just these mixed subtype samples. And that's true both for the invasive and the in situ component. When looking into the volcano plots, we really don't find a lot of proteins that really differentiate the subtypes, neither in the in situ nor in the invasive component. And even if we look into those classical markers of the different subtypes, yes, they do cluster for the respective subtypes, but it's not that they're not expressed in the other subtype, and some are even highly expressed in the other subtype. So what we concluded from this is that this is probably not a real binary classification, but rather something like a differentiation spectrum. Now looking into long-term outcomes and what are proteins that are associated with overall survival. This is now total cohort in situ component. Those associated with prolonged overall survival, we might call them boring, are very cell basic metabolism kind of pathways. Looking into impaired overall survival, these are all pathways that are closely involved with cell proliferation. So the more proliferation pathways we have in this in situ component, the worse our overall survival is supposedly going to be. Now looking into the histological subtypes respectively. So both the intestinal subtype, what impairs overall survival there, and the pancreaticobiliary subtype, what's decisive there. And interestingly, they are very, very similar. So in both of them, we see a switch towards cell proliferation in terms of pathways. And it's very, very similar pathways for both subtypes. So this is the in situ component. Then we looked into the invasive component. And for the intestinal subtype, again, we see this switch towards cell proliferation. But for the pancreaticobiliary subtype, we see something distinct that is clearly different. We see a switch towards catabolic processes. So something like really degrading. And these are all pathways that are also known to be somewhat linked to cancer cell invasion motility. So the invasive component seems to be the only one that's quite distinct for the subtypes when it comes to determining overall survival. So this is our first half of the cohort. We're currently adding 100 more patients because we have bigger plans also of validating something like adjuvant therapy and who benefits. But as of now, we know that histological subtypes seem to be rather a differentiation spectrum than like kind of a black and white category, and that proteins that are involved with cell proliferation and catabolic processes are probably most decisive for overall survival. They seem to be different between the subtypes. And with this, I'd like to say thank you to our fantastic proteomics lab in Freiburg, to all of our hardworking pathology partners, to our surgical partners, and of course to my surgical mentors at MGH and in Lübeck. And thank you for listening.
Thank you, Dr. Werner. That was excellent, nice presentation. It sort of was similar in some regards to the expression profiling study where there were two categories, but again, you did demonstrate that there is a bit of an overlap between the two. You know, in ampullary disease, we often have the opportunity to get precursor lesions like ampulectomies and ampullary adenomas. And seeing that there's a strong overlap of the two, meaning that they're driven really by the same pathways or by the same end molecules, you wonder at what point does a tumor switch from, and this is more academic than anything clinical, when does it switch from being a pre-malignant to an invasive lesion? And since those tumors are available, as you're doing more, I would actually urge you to look at pre-malignant lesions and try to determine what events occur at sort of the moment of invasion type thing in high-grade dysplasias versus your early, N0 cancers, and trying to do a differential analysis between those two, or almost like a potential, like where can we study switches to invasion? Yeah.
Yeah, thank you so much, Dr. Wolfgang, for this important comment. And I think that's kind of the key to really understanding that, as you said, the invasive part of it seems to be the most crucial. And I think the only way to really prove it is by looking at these early lesions and not seeing this. And I think the fact that we saw that in the transcriptomic study too, that the invasive part of the tumor seems to be the most crucial thing. I mean, this is mirrored by our clinical studies too, that say as soon as we have local regional invasion in these tumors, both for the intestinal subtype, which we showed more recently, but also for the pancreaticobiliary subtype, this is when we probably need adjuvant therapy.
I mean, in a theoretical level, when you think about it, it's the phenotype that is selected for, not the genotype or the expression profile. And so you're looking at the end molecule. But once the pitch is thrown because of the natural selection, everything is going to sort of evolve toward whatever is selected for, the more aggressive growth things. That's why I think looking at the other end, what starts to throw the pitch before they evolve down this common pathway of selection would be interesting in understanding sort of the initial events of moment of invasion and why do some of these remain adenomas and why do some progress?
I did have one question for you. I mean, again, this to me brings up the idea that can you use it to tailor your therapies? I mean, are you seeing things in the proteomics that are like what we look for in NGS, which are sort of targets for treatments that are already out there that could be used for these patients if they recur?
Yeah, thank you so much. I mean, obviously, this is absolutely what we're aiming for. And that's why we do have almost 200 patients now, but that's why we add another 100, because in order to really determine who needs the adjuvant therapy, you need a group you need one that responds well and one that doesn't respond at all in order to really understand that. And you all know this, identifying the ampullaries, they are rare overall. And if you have them, they have all sorts of heterogeneous regimens. So we really wanted to do this rigorously, to have these three groups in a proper sample size in order to derive a signature which we can take to the tumor board and be like, if these patients have these clinical parameters plus these proteomic markers, they need adjuvant. And that's kind of the goal of the study.
Thank you.
Very nice job. Thanks very much. Okay, our next paper is scientific targeting of pancreatic cancer in orthotopic mouse models with an anti-CA19-9 antibody conjugated to a near fluorophore, presented by Dr. Bravo from University of California, San Diego.
Good afternoon, and thank you for the introduction. We have no disclosures. Quick overview where we're going to discussing today, just some background information on PDAC. Then we're going to talk about prior work in fluorescence labeling of tumors. We're going to look at our pancreatic cancer cell lines and model creation and our imaging with near infrared light and SPI-Fi, as well as our future directions, and just go over quick conclusions. So PDAC is the third leading cause of cancer-related deaths worldwide. 5-year survival rate is 13%. Locally advanced metastatic disease is found in around 80% of patients. And serum CA19-9 is elevated in around 80% of patients with pancreatic cancer. And as we know, R0 resection is crucial to improve outcomes and survivability. So since CA19-9 is so prevalent in pancreatic cancer, the rationale for our study is to develop techniques to detect cancer and increase survivability by improving resection. Going over some previous uses of fluorescent antibodies for PDAC resection. A clinical trial in 2018 used Surgimab, which targets CEA, and used intraoperative SPY fluorescence. They were able to detect primary and metastatic tumors with a modest tumor to background ratios as seen in the image here. Another clinical trial from 2020 used anti-EGFR, panitumumab, and intraoperatively, they were able to find peritoneal metastases clearly, which is promising for future studies, as well as improved TBRs of 4. Another anti-EGFR, cetuximab, was used in 2019, and this is showcasing the sensitivity of fluorescent dyes. In this trial, they were able to detect lymph nodes smaller than 5 millimeters intraoperatively. As far as preclinical studies, there are a number of studies out there, just highlighting a couple here with anti-CA nanobody, which accurately detected pancreatic cancer, and the mucin family of molecules is also being studied, a MUC4 IR100 displayed here. So our molecule is an anti-CA19-9 antibody, and here are its characteristics. So the antibody, which is expressed again in 80% of cases of pancreatic cancer, is conjugated to IR-dye 800. IR-dye 800 has absorbance peaks of around 800 nanometers, which has a spectral overlap with ICG, which is widely and clinically available. This means that most clinical fluorescence laparoscopes currently available can be used to image this molecule. To create our subcutaneous models, we used the cell line SW1990, which is positive for CA19-9, and MIAPACA2, which is CA19-9 negative. We injected tumor fragments, small tumor fragments, into the flanks of mice and allowed the tumors to grow for around 1 centimeter before injecting the antibody conjugate via Tainveil injection. Here are our subcutaneous models. The image has a mouse with 2 tumors. The yellow arrow is pointing to the MIAPACA tumor, which is negative for CA19-9, and the white arrow on the right is pointing to the SW1990 tumor, which is positive. So as you can see, the antibody brightly and specifically targets the SW1990 CA19 positive cells, while having nonspecific or no targeting at all of a CA19-9 negative tumor. Panel C demonstrates significantly higher average tumor to background ratios for SW1990 compared to MIAPACA, and particularly 96 hours post-injection. These timing studies are important for clinical translation as well. For our orthotopic models, we used 2 different SW1990 and BXPC3 cell lines, both PDAC and both positive for CA19-9 expression. We implanted these tumor fragments into the pancreas of mice, and tumors were allowed to grow for around 3 weeks prior to tailoring injection. We injected mice with either 50 micrograms of CA19-9 IR100 or IgG IR100 as a control. For our study, we used the Pearl small animal imaging system, which is used for high-quality images under a control environment. So this is ideal for preclinical studies. And this is our orthotopic model using the Pearl. Panels A and A prime show the SW1990 images. The white arrows, again, are signaling the tumor, and the yellow arrow is pointing to the normal pancreas. We can see that the antibody dye conjugate brightly and specifically targets the tumor, as opposed to the panels B and B prime, which were injected with IgG, where there is nonspecific targeting. And again, in panel C, we have the TPRs, tumor to pancreas ratios, and TLRs of both CA19-9 and IgG, demonstrating specificity and promising TPRs. In this study, we also, to simulate a clinical trial scenario, we use the Stryker 1688 laparoscope, which is FDA approved and widely used clinically, as we all know, to test our antibody-drug conjugate. And we got these images from our orthotopic models. We have the mouse above, which is a SW1990 tumor injected with CA19-9 in panel A, and shows again specific targeting and bright targeting of the tumor with spy fluorescence and overlay, as opposed to panel B on the bottom, which was injected with IgG as a control. TPRs and TLRs were also significantly higher, and these are promising results for clinical translation. And our BXPC3 models also showed similar results. We have our pancreatic tumors on the left side with CA19-9 and IgG on the right side with no specific targeting. And again, TPR is higher than 3 for the BXPC3 orthotopic models. We also do fluorescence biodistribution analysis, which allow us to essentially determine the highest mean fluorescence intensity. Mice injected in both groups showed highest mean fluorescence intensity in the tumors compared to IgG, which has a higher fluorescence intensity in the liver, which is where it is excreted. And similarly, the BXPC3 cell line had similar results with the highest fluorescence intensity located in the tumors. We also have a histology. We have an H&E staining of pancreatic cancer on the left for both BXPC3 and SW1990, confirmed with PDAC. And to the right, we have CA19-9 staining, which was observed in the SW1990 and BXPC3 tumors. The SW1990 staining was more prominent, which is suggestive of higher expression of CA19-9. And as a control, the image on the far right, tumors treated with the isotype control IgG show no staining, no specific staining. As a matter of conclusions, we were able to create models in which CA19-9 brightly and specifically labeled labeled pancreatic cancer. Our orthotopic model TPRs were significantly higher than control. We achieved high TPR using spy fluorescence, which was comparable to clinical trials. And again, just a general conclusion, tumor-specific fluorescent antibodies are clinically promising tools for improving oncologic resection. And future directions, a metastatic model and lymph node analysis would allow us to determine the sensitivity of the labeling agent. We also would, additional studies using laparoscopic imaging devices and spy fluorescence would also prove a big step into clinical translation. And an important thing an important point is margin analysis. Is the border seen with fluorescence the true border when evaluated pathologically? So more studies evaluating these margins are necessary, as well as depth of penetration studies prior to full clinical translation. Thank you very much, and take any questions.
Go ahead.
Go ahead.
I'm just going to ask, I love this. It's very novel. The concept, I guess, of using it, to determine margins or to figure out whether you're going to be able to clear your margins. I guess, thinking about the question of sensitivity, I would think would be a major concern. And so, kind of what are your thoughts about that, looking for sort of microscopic disease or smaller amounts of disease at the margins, and how effective you think this technique is going to?
Yeah, thank you for the question. Well, the sensitivity is, pretty high, which we can see in the clinical trial with the anti-EGFR agent. But we have another model that we created on gastric cancer, which we were able to detect lymph nodes smaller than 1 millimeter in mice as well. So that's, it wasn't the same agent, but it was the same dye, and that's a pretty promising result. So yeah, we would definitely try to focus on our next studies to prove that sensitivity. Yeah, I hope that answers your question.
Go ahead, Chris. Nicely done work and nicely presented. One thing like maybe a little note of caution is that it's my understanding, I don't think mice express CA19-9. And some normal tissues express CA19-9 in humans, pancreatic or biliary ductal tissue, is to look at your antibody in human specimens because you have, superb contrast in the mouse, but they don't express CA19-9 background. You may find out that your background lights up in humans like a light bulb. And so just before we don't go too far, and I was wondering if you looked at human specimens. The second thing in application of this, one of it, you maybe touched upon it a little bit, is that something that would be clinically useful would be, a lot of times people, or we will do selectively a diagnostic laparoscopy looking for liver lesions that are below the limit of detection of MRI or CT scan. And we do that visually. We inspect a surface, we take ultrasound and we look for it. But, there's probably a limit of detection of something on the border of truly micrometastatic to grossly metastatic that we can't see, and working on your resolution and limit of detection using the SPY technology to be able to pick up really small lesions, because that's an instance where it would actually potentially change the operation. So it's really promising. Nice work.
Right, thank you. Yeah, I agree. The CA19-9 expression in mice is non-existent, and of course, if a tissue expresses CA19-9, the agent could definitely bind there. The reason we do the timing studies is to allow for some washout to occur, hoping that these normally expressing CA19-9 tissues kind of clear the antibody while the tumors remains in place. So 96 hours after injection, hope is that only a tumor, but of course we need to evaluate that in humans and potentially other animals as well. And to answer your second question, yeah, I think the main benefit of this particular agent, apart from distinguishing healthy and tumor tissue, is to be able to use a diagnostic laparoscopy and find metastatic disease or micrometastatic disease that otherwise wouldn't be visual or visualized with the naked eye. So yeah, by making more sensitivity studies and potentially a lymph node model, we can again kind of do a proof of concept that that's a useful clinical tool. Yeah.
Nice job. Nice.
Thank you.
Great. Our next paper is identification of novel CAF subpopulations and clinical prognostic correlations in pancreatic cancer using single cell and spatial transcriptomics. Don't mean to make you run. Presented by Zhangpo Chen from Nanjing.
Good afternoon, distinguished professors. My name is Chen Chongfa from Nanjing. My presentation title is Novel CAF subtype in PDAC tumor microenvironment. Discovery of AG-CAF and its clinical implications. We have nothing to declare. Our first topic is the key role of the tumor microenvironment. Current chance shows that the prognosis of PDAC depends on the tumor microenvironment, which compares on the CAFs, primarily including the ICAF and the MyCAF. But the problem is the targeted therapy against the non-CAF have not improved the 5-year survival rate of the PDAC patients. So we have one question. Are there other CAF subtypes impacting the prognosis of PDAC patients? Using single cell and spatial transcriptomic data to explore this problem. And using the CSER algorithm can help us to directly identify CAF subtype associated with the people's survival. The material including this topic are single cell sequencing data and spatial transcriptomic and bank RNA sequencing data. After CSER analyzing, we found that prognosis heterogenetic cell memory located in the fibroblast and the ductal cells, and the class 2 CAF are the most significantly associated with the poor prognosis. Detailed gene different analysis show that the marked gene of the class 2 CAF is ADM, and the class 2 CAF mainly involved in the HIF1 alpha and the aerobic glycolysis pathway, and the hallmark gene of the CAF are mainly expressed in the class 2 fibroblast. So class 2 fibroblast shows the CAF phenotype. Further analysis found that there are 4 kind of gene co-expression danger in the calf. The other 3 subtype has been reported, but class 2 calf haven't been discovered. And the characteristic gene expression module of the class 2 calf is module 4, 7, and 11. ADM is expressed in the module 7, and module 7 involved in the HIF1 alpha and aerobic glycolysis, which shows the class 2 calf phenotype. Because of these unique gene features, we name this aerobic glycolysis associated calf as AG calf. Now we want to see where this AG calf located in the tumor. We're analyzing the facial transcriptomic data and found this ADM is high expressed in the AG calf. And the iCalf, myCalf transform into AG calf towards the tumor edge. And these areas are not only associated with the poor prognosis, but also associated with the AG calf distribution. So we have another question. Could the poor prognosis in the PDAC patients can caused by the calf transferring into the AG calf at the tumor margins? To answer this question, we collect 40 cases of PDAC clinical samples, and the result shows that ADM is high expressed in the AG calf. The distribution of AG calf is also spatial, different from the whole known calf subtype. And the heat map of the AG calf distribution shows that the AG calf mostly located at the tumor margin. So the next question is, what caused other calf subtype to transfer into AG calf at the tumor edge? So because HIF1 alpha and the aerobic glycolysis both link to the oxygen level, so we explore the role of the hypoxia in the transferring of calf subtype in PDAC. The result is the transferring of the calf hypoxia played a key role in the transferring of a calf subtype. This topic material including the RNA sequencing data from the primary calf, which collected from the tumor margin. After the convolution of RNA sequencing, we found one primary calf is AG calf phenotype. Further analysis shows that the AG calf phenotype involved in the HIF1 alpha and the aerobic glycolysis in the virtual experiment. And the more important thing is hypoxia can significantly promote the AG calf phenotype. The final question is, can AG calf serve as an important factor for predicting clinical prognosis? After clinical relevance analysis, we found that AG calf is associated with the lymph node metastasis and overall survival, local recurrence, and distant metastasis. So in conclusion, AG calf's marker gene is ADM and involved in the HIF1 alpha aerobic glycolysis pathway and also associated with the poor prognosis. And the distribution of AG calf is located in the tumor edge. This is our acknowledgement. Thank you for your attention. I'm happy to take any question. Thank you.
Go ahead, Dr. Wolfgang.
Yeah, Chungfal, that was really wonderful work. Congratulations, nicely presented. You looked at the spatial distribution of the AG calves.
Yeah.
Have you looked at the adjacent parenchymal malignant cells? Is there anything different about them? So do they tend, because that distribution is not even throughout the tumor. Do they tend to be more stem cell-like, or do they tend to have more mesenchymal phenotype than the background of the remainder of the tumor in a spatial thing? Is there co-localization of your AG calf with mesenchymal or stem-like cells?
Actually, I have do some biological data analysis. When we found the microphage cells maybe is close to this AG calf, and these two calves interaction maybe take a very important role to promote the tumor progression. Thank you for your question.
So just a little bit more response to Dr. Wolfgang's questions earlier. So the thing is, we haven't done a clustering of the tumor cells in our study, but that's definitely an interesting thing to do, and we'll do this later. But I think a more interesting thing about this cluster is that this subtype is that so they mainly locate at the tumor stroma interface, or sometimes tumor vessels interface. So we surgeons simply have an idea that if the tumor can shrink from the artery, then it will be easier for us to resect. So ideally, if we can find a treatment to target this special subtype, then it's there will be better chance for resection of the artery involved patients.
Yeah, it's great. And I was thinking more on the lines, does this play a role in the, what makes a disease systemic? Does this aid in the systemic sort of distribution of disease? Is it involved in the process of development of circulating tumor cells by aiding the process of going through surgery, which the most malignant type or the most aggressive type are the stem cell or mesenchymal type. And it's interesting why are they around vessels and why are they at the periphery?
I'm Professor Jin Young from Seoul, Korea. So thank you for very excellent data. So I have some questions. So several subtype of cough, so must coexist according to the situation. So I want to know how can you define the age cough according to the expression of the cough level. So I want to know the threshold about the specific gene expression. So second question is the CAP is, I think, some of the environment-related factor. So you showed that in your 40 patients, so there is some sub-classification of CAP can be useful. However, I want to know about the neoadjuvant treatment or the stage matched the expression of your CAP subgroup. Is there any specific relation with the age CAP? My third question is, age cup has some role. How do you anticipate the age cup in the environment with the tumor in pancreatic cancer?
The first question, I thank you for your question. The first question, how I cluster in this new subtype CAF in my biological analysis. I think the first important parameters is the HDWGNA. It's called the gene cooperation module analysis, and this algorithm is calculated by the unsupervised clustering. So I think it is very operative method for to find this new subtype CAF. And the second question, I think, actually we have extracted this new subtype CAF from our biological clinical sample. So and we perform the RNA sequencing to evaluate this new subtype, and we found it is very different from the other subtype.
There is no correlation with the neoadjuvant treatment or the advanced stage in your clinical setting?
What?
You performed the 40 cases of this study. So is there any correlation of the age cap with the neoadjuvant treatment or some kind of the advanced stage?
I think the 40 cases included here are basically all chemo-naive patients. So we can't see the analysis here.
Thank you for your question.
Okay, very, very nicely done. Thank you. The next paper is entitled Pancreatic Duodenectomy with Intraoperative Radiation Therapy for Borderline and Locally Advanced Pancreatic Cancer, a propensity scored matched survival analysis presented by Dr. Barastegui and colleagues from the Mayo Clinic, Florida. And can you correct my pronunciation of your name? What's it?
Barastegui.
Barastegui. Thank you. Sorry. Top green, yeah.
Thank you. Thank you. Thank you. I'm excited to present our results. Nothing to disclose. As we all know, pancreatic cancer is one of the deadliest cancers in the world. The role of intraoperative radiation therapy is controversial, especially for the use and the management of pancreatic cancer. In our center, we have adopted the routine use of intraoperative radiation therapy for the management of borderline and locally advanced pancreatic cancer. That's why in this study, we aim to compare overall survival and local failure recurrence, as well as preoperative and postoperative outcomes between patients with borderline and locally advanced disease with pancreatic ductal adenocarcinoma who received intraoperative radiation therapy compared to the ones that did not. We performed a single-center retrospective cohort study at Mayo Clinic, Florida, that spanned from 2010 to 2024, of which all patients received neoadjuvant therapy, as well as radiotherapy, followed by surgery. Our statistical analysis was that we performed a one-to-one propensity score match based on patients' comorbidities, demographics, cancer history, as well as neoadjuvant and adjuvant therapy to control any type of biases. From 737 patients, only 173 patients had a borderline and locally advanced disease, of which, after exclusion and matching, we came across with 108 patients, 54 for the IRT group and 54 for the control group. From these, our results regarding the baseline characteristics were comparable between the two groups. The only differences observed for the baseline characteristics was that there were more patients in the IRT group that had a locally advanced disease. Regarding the perioperative outcomes, such as estimated blood loss, operative time, as well as length of stay, the results for both groups were comparable. And in the postoperative outcomes, in the first 90-day period after the surgery, no patient had any type of added morbidity nor mortality. The pathological features, such as lymph nodes resection, as well as marginal status or lymphovascular invasion, was similar for both groups. Moving to the recurrence and the survival analysis, there was no statistical significance for the distant recurrence between these two groups. However, we found out some striking results comparing it by local recurrence, having the IRT group only 10% of local recurrence after the 24 months of follow-up, compared to a 34%, sorry, of the patients that did not have any IRT. Looking at the overall survival, there was an improved survival after the first 24 months of the follow-up for the IRT group, having a number of close to 60% compared to the control group that only had about 40%. Finally, the multivariate Cox regression analysis showed us that the only predictor that showed added benefit for the overall survival was the use of IRT, having a hazard ratio of 0.56. With these findings, we can conclude that IRT has an improved local control as well as an improved overall survival, and there was no added morbidity for these type of patients. Just a special thanks to Dr. Stauffer for all of his mentorship and his help. And thank you, everyone. Ready to answer your questions.
We're running a little bit late, but I did have one question for you. I mean, this is kind of a remarkable difference, which brings me to question it honestly. I mean, so did the IORT guys get compared to people that didn't have any radiation? So they got no post-op or pre-op radiation therapy?
Yeah, both groups have neoadjuvant therapy as well as radiotherapy. All of them.
They did. They
Yes.
had external beam
Yeah,
pre-op, and then the IORT had.
Exactly.
Okay, I mean, what is your sense for that? I mean, it's rare to see a survival advantage of that magnitude in this disease. So how do you feel about that? I'm sure you're going to tell me it's reliable, but.
Yes,
seems
definitely.
amazing.
This, as well as the number of patients for these studies, are relatively small. Larger studies are needed to confirm this data. But that's why we perform the propensity score match to account for all these type of variables, such as comorbidities and the type of neoadjuvant regimen, which could account for any type of biases.
Okay, thanks. Nicely presented. Thank you.
Sure.
This time?
Yeah, go ahead.
Yeah, so first of all, congratulations, well presented, Marco Del Chiaro, University of Colorado. So I have to declare, first of all, that I'm not a good really a big supporter of radiation. But I think on my side, there are a lot of prospective randomized trial now that show equal results or worse with the radiation. Now, I could agree on everything on this study, but conclusion. I think in a retrospective study, you cannot say that this study demonstrate overall survival better local control. I think you need prospective randomized trial. I think the literature data are not really supporting very much your conclusion. So my recommendation is to investigate further. I think these preliminary results are extremely interesting, but I would be careful to say that, I mean, you demonstrate something, because I don't think that's correct.
Yeah, definitely right.
Thank you.
I completely agree. We need more prospective type of studies for this type to have this type of conclusions, right? And as well as more centers to join this type of management.
Great,
Thank you.
Okay, so our final paper is a global survey on surgeon preference and current practice for pancreatic neck and body cancer with portomesenteric venous involvement by Dr. Ishida from University of Colorado.
Good afternoon. My name is Hiroyuki Ishida, a research fellow at University of Colorado. So I'd like to present our results of our global survey study on pancreatic neck and body cancer with portal vein involvement. Yeah. Okay. So I have no COI to disclose. So what is your practice for pancreatic neck and body cancer with portal vein involvement? Surgeons may consider three options: rectal pancreatectomy, pancreatoduodenectomy, and total pancreatectomy with portal vein resections. But in decision-making, surgeon must carefully strike a balance between complication risk and oncological benefits. However, the evidence on this topic is scarce, and the process of surgical decision-making may vary depending on the experience and surgeon's preferences. So the aim of this study is to clarify the current practices using global survey. So we conducted a global survey using Google Form, which was supported and distributed by international HPP societies, including Pancreas Club. Only surgeons who performed PVR in the last 12 months were asked to complete the survey. Questionnaire included general questions, decision-making processes, and procedure selections for hypothetical clinical scenarios. We created 3 scenarios with increasing degree and length of portal vein involvement, with type C being the most extensive. A total of 222 surgeons from 49 countries across 6 continents participated in this survey. In scenario A, left pancreatectomy with PVR type 1 was most commonly selected. In type B, left pancreatectomy with PVR type 2 or type 3 were frequently selected. And scenario C, however, pancreatoduodenectomy or total pancreatectomy with PVR type 3 were frequently selected. We also asked about procedure selection in cases of additional common hepatic artery involvement. In scenario A with additional common hepatic artery involvement, the most selected procedure was left pancreatectomy with PVR plus CHL resection without any arterial reconstruction. The result was same in scenario B plus additional common hepatic artery involvement. However, in scenario C plus common hepatic artery involvement, all types of pancreatectomies were widely selected. Interestingly, subgroup analysis per continent show the regional differences. The most commonly selected procedure for type C was pancreatoduodenectomy with PBR in Asia, total pancreatectomy with PBR in Europe, and left pancreatectomy with PBR in North America. This trend was consistent in cases of common hepatic artery involvement. So in conclusion, this survey illustrates the heterogeneity in surgical management of pancreatic neck and body cancer with portal vein involvement. Future prospective studies and guidelines are needed. Thank you very much for your attention, and thank you very much for the great support by Pancreas Club.
It's very interesting and very well presented. I think obviously this subject is super interesting, and it's complex and challenging to get meaningful data about surgical decision-making on sort of a broad spectrum like that. Did you ask more specific questions like about factors maybe that went into decision-making in terms of, for example, consideration about gastrectomy, concomitant gastrectomy for, vascular supply afterwards, or other things that may lend towards surgical decision-making?
Thank you very much for your question. Yeah, this is a great point, but to simplify the questionnaire, we didn't include the additional question regarding the gastrectomy or some reimplantation of the gastric vein or IMV or something like that.
Super.
Yeah, I had one question. What did you expect to get from the survey? I mean, besides a variation in responses from different people across the country or world, were you expecting to get variability geographically, or, I mean, what was the expectation kind of going in? Were you looking for the right approach?
Yeah, I think interesting is the use of total pancreatectomy in some countries and some continents. It may expect some tours about the use of total pancreatectomy. Like in Europe, they prefer to select total pancreatectomy compared to other continents. But in the next step, maybe we should consider the patient-specific factors and then the procedure selections.
Okay, well, thank you. Very nicely presented. And well, I guess we'll conclude by saying thank you to the audience for their participation. The discussions were great, and the presenters did a nice job.
And then if you don't mind, hang on for 1 second. Dr. Zaromsky has an announcement to make. Sorry.
We have a great discussion today and great papers. We are running behind a little bit. We will take about a 12-minute break and come back to start the final session at 4:10. 4:10. So say hi to the exhibitors, please. Tell them how much you enjoy having them there, and we'll see you back here in a few minutes. Thanks.